moving on to the next and the last session of the day. On behalf of CADRE 21, E-Symposium on Caries Diagnosis and Research, we welcome Dr. KRITHIKA to talk on current concepts in etio-pathogenesis of dental caries. And I take my pleasure in inviting the moderators, Dr. Pratima Shana and Dr. Ramya Raguna. Dr. Pratima Shana is presently Professor and Head of the Department of PFPM Dental College and Research Center, Nagpur. To her credit, she has registered 4 patents for research with the Government of India, and she has contributed to several endodontic and operative textbooks. We welcome you, ma'am. And Dr. Ramya Raghu is currently Professor and Head of the Department of Conservative Dentistry and Endodontics, Bangalore Institute of Dental Sciences and Hospital, Bangalore. To her credit, she, along with her husband, Dr. Raghu Srinivasan, has authored 2 textbooks titled Clinical Operative Dentistry, Principles and Practice, and Endodontics, Current Concepts and Practice, which have been well received by dental students and clinicians in India. Now, I request the moderators to take over to introduce our speaker.
Ma'am, kindly unmute, ma'am.
Can unmute yourself, please?
Okay. So a very good afternoon to all of you. I begin with appreciating and applauding the efforts of SRM Dental College under the dynamic leadership of Dr. Mahalakshmi Madam for this much needed symposium on caries. I also record my deep sense of gratitude for making me a part of this symposium. Thank you, Madam, so much. It's a real honor. I have been listening to the lecture since morning. Dr. Abhishek and Dr. Ramya has really brilliantly spoken on the subjects, and it's given us a good insight on all what we can do. So I think it was one of the most needed topic in today's time, as we all believe that caries is one such topic which is the very foundation of dental specialty, and we need to address it all from all directions with all the contemporary technologies available to us today. Now we have another one of my very favorite speaker, Dr. KRITHIKA Datta. Her formal resume is as impressive as her personality. I will quickly highlight few of her achievements, especially so that the youngsters listening to this will feel motivated to achieve more. So, Dr. KRITHIKA Datta is a professor and head of Department of Cardiology at Savita Dental College, which she has set up on her own. This department is first of its kind in India, and I think we all should appreciate the efforts Savita Dental College is doing towards this very important topic in dentistry. She is a passionate researcher, and her area of interest is cardiology, especially caries and its dynamics in Indian population. So Indian population, as we all know, is very much affected by this pandemic kind of caries that we face in our practices every day. And here again, I must compliment all Indian population today for having 100 crore vaccination. So I think if we set our minds to it, we can achieve everything we want to. And caries, control of caries could be also one of this thing. Coming back to KRITHIKA again, she is a member of the prestigious European Organization for Caries Research since 2010, and she was the recipient of the prestigious Best Young Dentist Award instituted by the MGR Medical University, Tamil Nadu. Also, Young Achiever Award instituted by Conservative Dentist and Endodontist Association of Tamil Nadu. To her credit, she has numerous publications in indexed peer-reviewed journals and is herself a reviewer for the Journal of Endodontics, Journal of Prosthodontic Research, and other national journals. She has served as an editorial board member in Clinical Oral Investigation and is also an associate editor of, and was an associate editor of Journal of Conservative Dentistry from 2008 to 2015, and is now appointed as an advisor of Journal of Operations. She has over 100 invited guest lectures to her credit. And as a very senior academician, I have followed all her lectures on various platforms. And it is a delight to listen to her well-researched, crisp presentations. So I invite Dr. Krithika to enlighten on this topic today. And I am looking forward to listen to you once again, Krithika. All the best. And thank you again organizing for this opportunity. Thank you.
Thank you, Pratima ma'am, for your very kind words. It is indeed a pleasure to be moderated by you. I have known you since my post-graduation days. In fact, both my chairpersons, I am an ardent fan of theirs. And it's all from you that we have learned and trying to carry on the legacy that you have set forth for us. Thank you so much for your kind introduction. Now, I would like to start the presentation with this question. Actually, it is a preventable disease. It's not rocket science. It's not even COVID-19. It's a simple lifestyle disease that can be easily preventable. And yet we are struggling to get hold of this disease, especially in India. So my context of what we are going to talk today and discuss today is entirely going to see how we understand and go about this disease so that our population benefits. My focus is not on what others are doing abroad, but try to see how to understand this disease in whole so that we can help our patients right from the doorsteps of our clinics and colleges. So let me just present this data to you. This is the dental caries prevalence in world scenario, which was published as a systematic review in 2015. And this data is in the pediatric population. Okay, so this basically gives the red areas are all highly caries prevalent countries. And the ones that are in blue are non-prevalent. So every other shade is somewhere in between. And well, apparently, it is seen that India is marked in red in color. It goes, it's in confirmation with our logic because we know that everybody around us suffers with this disease. Now, the same publication also had the charting done for the adult population. Here you see India prevalence is second best, which goes to say that somehow adult population in India don't suffer with dental caries. Yeah, it was quite surprising when I went through this publication as to what are they trying to tell. And then I went back to the references and seen what are the articles from which they have collected this prevalence data. Unfortunately, there have not been many reports on adult caries population data in our country. So that's why it is not represented well in the global scenario. Whereas there are a lot of prevalence studies on dental caries, burden of illness of dental caries in the pediatric population, which means pediatrics are doing their job. We are yet to begin. So with this mindset and with this outlook, I just want to see why is it, why caries is not being discussed big in our country. I've been trying to understand and work in dental caries for the past decade. And whenever we write for grants and whenever we try to approach funding agencies, usually dental, any kind of dental study is shot down unless it is something got to do with cancer or something got to do with viruses. So this happens because in India, this is the data from 2016. The 10 top common deaths happening in India is top being heart disease. And you can see that we are already struggling with a lot of problems inherently in our country. So the medical issues take in a huge chunk of focus when it comes to health, and dental issues take always a backseat. There's always easy to say that what if you lose one, you have another 31 in your mouth. So that's the attitude and tendency when the funding agency or even health policy makers of India will look at our disease. So what are we left with now? We don't have funds to do this work, and it's an easily preventable disease. We still don't have data. So these three areas itself is enough for us to take up and commence our work in dental caries. And here at this moment, I would really like to appreciate Mahalakshmi ma'am for taking this tangent from what we usually do in our specialty. It is always and almost always only endodontics. So I think it is really nice and warming to see Mahalakshmi ma'am and her team take this up. A huge congratulations to you, ma'am, for focusing on dental caries as well and organizing this 2-day national symposium with lectures from India and across the country, across the globe, and also have students to present in this. Thank you for this wonderful opportunity. We all feel honored to be a part of this. Now, having said this, let's see whether we are awakening to caries just as yet, or was something being told long before. So I will just give some time for you to read this. I'm not going to talk, just read what is written on the slide. So G.V. Black, about a century before, not even a decade, not 10 years back, 20 years back, but a century before, had said that our complete divorcement from understanding the pathology of dental caries is an anomaly in dental science in itself, and it should not continue. If we don't understand what is happening, then we continue to function as dental mechanics. Unfortunately, 100 years and over since then, Professor G.V. Black's statement, I don't think we have made a drastic change in how we look at the disease. It's because we are probably caught up with other things, maybe much more fancier things. And I've always seen that in India, research or clinical practice is all driven by companies. So I think we need to take a step back here and see what is actually happening to the tooth that is probably one of the most prevalent diseases next to common cold. So I would like to here mention that my journey in this field is actually not alone or single. I've not done anything single-handedly, but I've had good mentors. Usha ma'am, all of you know. The other two gentlemen is Dr. David Manton, who introduced me to cariology in 2010. Professor Dominic Zero, whom I met in 2013, and Professor Dr. Anil Kishan, who is a constant source of support and inspiration, a good friend and guide in my life. It's because of these people who keep inspiring me and who believe in me that, yes, you are thinking right sense, you should probably go forward. If not for them, I don't think I would have taken this tangent up away from mainstream specialty and looked at cariology any differently. And another space which has a huge impact in my life professionally is ORCA, the European Organization for Caries Research. It's a phenomenal body. They've been researching, it's been in existence for over 70 years now, and the kind of work and contribution that they've done to world scenario is phenomenal. Now they are branching out to see how they can solve problems in developing and underdeveloped countries, and they are very keen on collaborating with our country in specific. And I've had the opportunity to represent India at ORCA on several occasions, and they are willing to extend support to us. So that's a huge thing. I would urge for those who are interested in cariology to kindly consider becoming members of ORCA. Mahalakshmi ma'am is already a member. She's been a member for a while now. And maybe that's how she's got this insight to think differently. It will definitely make a huge impact. It has done for me. So please consider ORCA, joining ORCA at some point if you're really interested to further your work in cariology. Now, this disease has seen several changes ever since its discussion ages before. And so is the definition and the concepts. Everything has been changing. It's not like something which is stationary and stagnant. It's a dynamic disease. And the concepts also around the disease are pretty dynamic. And I urge everybody to kindly look into the terminologies for dental caries that has been put forth jointly by IADR and ORCA, published in 2020 for all current statuses on risk assessment, definition, and everything. In fact, the definition itself has undergone tremendous change. Now we define dental caries as a biofilm modulator. Please consider when you read this definition, every word is thought out, researched, and then put into the definition in its order of importance. It's a biofilm mediated, diet modulated, multifactorial, non-communicable dynamic disease that results in the net mineral loss of dental hard tissues. So every word in this is important, and this itself kind of summates the etiopathogenesis concept of dental caries, because there's nothing beyond this. So you could say that this is all inclusive, that there's nothing beyond this actually. But if we target at understanding dental caries from each of these words, I think then our understanding will be pretty comprehensive. Moving on to etiopathogenesis, we all know that it all started with Keys rings, and then time was added as a dimension, that all these primary factors need to be present over a period of time for us to develop tooth decay. This is what I learned during my undergraduation days few decades back. And now, then later on, they added on saliva as being a very important factor, which is undeniably true. We heard a very comprehensive lecture by the previous speaker on saliva and its importance in dental caries. But now, recently, they've been researching on what else causes factorial. When you're saying multifactorial, they've tried to explore all the factors and see what are all the factors that are responsible. Now the Keys rings look something like this. And I think possible to talk about how the disease develops from the influence of all these factors would probably take a week or 10 days time. And just to show things in perspective, I in PubMed just ran these searches. You can see that amount of research hits that the word etiopathogenesis and dental caries hits that. It's close to, even if you remove duplicates, it's close to 20,000 articles, which discusses the etiopathogenesis of dental caries. It's huge. I mean, it's so complex, and so many dimensions have been researched and reported. The concepts that were reported 10 years back are no longer relevant now. Newer concepts have come in forth. So anything that we deal with dental caries is dynamic. So we can't just hold on to one thing and then continue believing in that is what we need to eradicate. So we need to change and keep ourselves updated for us to know what is happening. So just reading textbooks for dental caries will give us fundamental understanding, but it also needs constant updation on your scientific platform. Just to summate, what causes dental caries is basically a balancing act between the pathological factors and the protective factors. When the concept sways towards the pathological factors and a person has more number of pathological factors compared to the protective factors, he develops disease. And we all know this. This is not something that is new. Only that different things have been researched in both sets, the protective factors as well as pathological factors, and more information is coming. Though we have so much quantum of information, nothing is confirmatory or concrete. So we are still trying to have this balancing act in place and try to always maintain our patients in low risk. Now, the hypothesis that leads to, when we say etiopathogenesis, we have to first understand how they have described this dental caries and how, based on research, how they have put forth different hypotheses. We're not going back to the previous age-old hypothesis like legend of worm and all that. Is just for academic interest, but the actual essence of dental caries as a disease started when people started talking about the plaque in itself. So they identify specific organism in plaque, that is Streptococcus mutans, which was found to be implicated as the most significant contributor for causing dental caries. Then a decade later, another group of researchers came forth and said it's not just Streptococcus mutans, but it is also whole other bacteria along with Streptococcus mutans. So we don't have a single cause effect kind of a relationship with dental caries. So even in microorganisms, it's multifactorial. There are many bacteria that are present that causes disease. That was established by non-specific plaque hypothesis. Later on, the understanding expanded that it's not just the bacteria that's present in your mouth, because now we know that we have 700 and odd bacterial species that can be isolated from human saliva. But it's not just the bacteria that's causing the problem, but it's the niche or the ecological niche at a particular site, which is different from the normal site that causes the problem. And there came the ecological plaque hypothesis by Marsh. And this has been the most prevalent and most predominantly accepted hypothesis, which says that it all begins with frequent intake of sugar. It all starts there. So when you take more of sugar, there is an increased acid production because of the bacteria fermenting the sugar and using it for its own resources. This causes an environment shift from a neutral pH of saliva or an ecological niche. It shifts directly to a low pH environment because acids are constantly produced. And also with this, there is a complete ecological shift. That is, the bacterial ecology that is present in that particular site is also replaced by disease-causing or pathogenic microorganisms. So when we say Streptococcus mutans, it's actually a commensal. It's not something that gets inoculated along with sugar. It's there in our mouth, but due to differences in the environment, it gets self-selection. Like sugar is its trump card. It starts playing itself, and their population increases, thereby suppressing the oral commensals. And this causes the risk to dental caries, and basically disease sets in. So you have, it all starts with sugar intake, which changes the environment. This environmental change in the oral cavity shifts the ecology from favorable bacteria to unfavorable choice of bacteria, which further causes the disease. An extension to this ecological plaque hypothesis was given by Takashi and Iward, which says that the teeth are always in a dynamic stability state. It's not that it's always healthy and always intact. It is in a dynamic stability state where there is constant removal and replacement of calcium and phosphate from the tooth material. It's only when there is more of sugar intake, there is a shift into an acidogenic state, wherein more acid is produced. And this acidogenic state by certain bacteria causes an acidiuric stage, wherein only the bacteria that can thrive in an acid environment gets chosen into the plaque. So this causes a net mineral loss. So when the dynamic stability state is lost, there is a change in the type of bacteria, and there is also equal and proportionate loss of minerals from the tooth structure. This was the extension for the ecological plaque hypothesis. In the last decade, there has been a lot of focus on molecular techniques, molecular microbial techniques, wherein they've stopped actually studying too much about microorganism itself and started going into its life and seeing what it does. So we have a whole range of molecular assessments that have been happening. If you see publications in dental caries, the burst of publications from 2008 onwards is actually phenomenal, because thanks to these kind of molecular techniques. So they are trying to see how is the bacteria, what is inside the bacteria. That is your DNA approaches, the genetic makeup of bacteria, the proteomics, what are the proteins involved, and what is the translation or the enzymes involved in the disease process, and what is the metabolism involved. So that is the metabolomic part. So all these actually have helped us understand the disease from a very micro environment perspective. And that has led to something like this called as the tissue dependent hypothesis of dental caries, which states that based on the tissue, now we know that ecology changes in case of dental caries to initiate. Along with ecology, you have mineral loss. Now this ecology itself shifts when it goes from enamel caries to dental caries. So that is your tissue dependent hypothesis. So they say that it's not the same ecology that is there for enamel caries that continues with your dental caries. So if you see, S mutants will not be there in dentine caries. It will be more of proteolytic organisms, and because it needs to degrade your collagen network as well. But in enamel caries, you have predominantly acid producing bacteria, because it needs to degrade the calcium and phosphates of the tooth material. Now, latest what is being put forth 2020 is the hypothesis, which is the integrated hypothesis for dental caries and periodontal diseases, which identifies, which basically the hypothesis states that the common culprit for both diseases is fermentable carbohydrates. That's what they hypothesize, because they say that the tooth or the oral environment is not in a neutral state ever. It is always in a dynamic stability state that I have already told you. The same holds true for gingival diseases as well. You can't say that there has not been a single person who has experienced, not experienced gingivitis. We all experience gingivitis, like how we all undergo demineralization. So this dynamic stability state is a constant phenomena in life. The problem arises only when we consume more of fermentable carbohydrates. Now, this carbohydrates is nothing but source of energy for the bacteria. If the and this source, this intake of carbohydrate is constantly defended by host defense mechanism, which includes the saliva, the tooth itself, and the GCF in case of periodontal diseases. Now, for some reason, if these parameters are on the lower scale and fermentable carbohydrates are on the upper scale, then depending on where the plaque is populated, it either goes into an acidogenic and acidutic state if it is supragingival plaque and causes dental caries. But if the GCF is getting totally deranged, then the population of proteolytic bacteria predominate, and it leads to an inflammatory stage causing periodontal, gingival and periodontal destruction. So they say that it finally boils down to what we eat. And it is something that's very simply said, but very difficult to control as well. But this is what is now being researched on and debated on, as to see how we can control this sugar intake. Now, the process overview, what happens in the etiology or the problem with the disease that sets in is just summated in this diagram. You have some intrinsic factors and extrinsic factors. In the intrinsic factors, you have the green ones, which are defending the disease, and the red one, which is a single source, fermentable carbohydrates, which is causing the disease. So the fermentable carbohydrates and the damage done by the fermentable carbohydrates are constantly rebutted by your host defense, your oral hygiene measures, saliva, and fluoride. Other things that are the extrinsic factors, this is what's happening inside our oral cavity. The other things that's happening outside, which is not common to all of us, is the kind of educational background we have, economic status, income, genetics, age, and the dentist. Now, let me pause here and ask you all a question. How much has your DMFT index changed ever since you started, ever since you've been a dentist? We should ask all of us this question. What was your DMFT status at the time you joined BDS? What was it when we were MDS? And what has it been ever since? I think that my DMFT status has not changed since my second BDS, because that's when I actually became aware of the disease process. So education is very, very important. It's not just what degree you hold. It's not that an IIT professor will have a lesser amount of tooth decay, but it's just the understanding or the knowledge of what this disease is. Because we don't develop dental caries because we know what to do and what not to do. It's the same thing that needs to be just communicated to our patients so that they will remain informed as to what is allowed and what is not allowed. Next is the socioeconomic status. This is something that's beyond our control. There's a huge disparity in access to healthcare. In India, they really cannot do much about it, but a blanket preventive approach will probably help offset the problems associated with these two extrinsic factors, the economic status and the income. Genetics is something that we carry on. We know that the genetics of increased caries incidence actually comes from your mother's side. If your mother has more dental caries, then the offsprings are bound to have more dental caries. And we know that with age, there is a lot of changes that happens. It does not need any explanation. But I'm interested to talk about dentists. The role of dentists in etiopathogenesis of caries. What do we do? What do we do to prevent this disease? If you take a college setting, which department is actually handling in preventing dental caries? do we have a strategy to help our patients to prevent dental caries? So this is a very important extrinsic factor and a very significant one. Nobody is going to fund this concept or this disease. So it's only up to us to make sure that we have checks and balances in our clinical practice or our college setting to help our patients be much aware and educated about this disease so that we can intercept the etiopathogenesis of the disease. Now, as I told, there is so much of information on the pathogenesis of dental caries. It's impossible for me to discuss everything, but we've tried to summate the entire into these 4 factors because these are the primary intrinsic factors that play a vital role when it comes to dental caries. First and foremost is the dental hard tissue. Now, the plaque that is formed on this hard tissue is responsible for demineralization. And it depends on where it is located, what is the morphology of the tooth, where it is located, what is the composition of the tooth in which it is deposited, the ultrastructure of the tooth, and the post-eruptive age. Nature has always given us the adequate defense to combat any disease for that matter. And dental caries is no immune. In fact, the nature has thought it in a good way to prevent this disease. So if you see, this is a cross-section of an enamel prism. We know it's a hexagonal in shape. It has an interior crystal and it has an adsorbed ion layer around this enamel prism. And around this is a hydration shell, which is basically a thin film of water around every enamel crystal. What is the purpose of this arrangement? It is basically to prevent the escape of calcium and phosphate from the prism. So it first gets, so when there is an acid attack, the hydration shell kind of tries to neutralize that acid, and the adsorbed ions, which is calcium and phosphate ion, tries to buffer this acid. Only when this mechanism fails and the acid influx is more, the interior crystal starts demineralizing. And also, if you see the way enamel is deposited, you have all the following that's there on your right side. All these elements that are basically anti-cariogenic in potential are deposited more on the exterior of the enamel. And as you go interior, that on the right side, they are all acid neutralizing your water content, carbonate content, magnesium, and sodium. They are all acid neutralizing constituents. So by nature, it is actually enamel is a pretty good defense mechanism to prevent the disease. It's just that we need to make sure that everything, the balance is maintained. And what happens when it breaches this balance? What happens to the tooth structure? It's a very simple concept. You have acid diffusion from the plaque and it diffuses under the tooth. So the layer that is present between the plaque, the superficial layer, actually does not undergo demineralization because of a lot of reasons I'll explain next. So it goes through the surface enamel, goes into the subsurface of enamel, and there you have dissociation of acid, which kind of removes the calcium and phosphate from the enamel prism, starting from the periphery, makes them into a solution. These salts get expelled out in order to come out and buffer the acid present in the plaque. So you have undissociated acid entering the subsurface of enamel, which further dissociates into H+ ion, which actively erodes the calcium and phosphate. So calcium is removed because phosphate wants to buffer this acid. So phosphate and calcium come out. They try to neutralize the acid within the tooth, and the ions also leach out of the tooth surface to neutralize the acid present in the microenvironment. That's how the calcium and phosphate are removed. Now, if the plaque is removed, then these calcium and phosphate that are present in saliva will push it back into the tooth surface. But if this plaque is not removed from this place, say for more than 2 or 3 days, that's when active demineralization continues. Now, where are these areas that it can get stuck? These are all your vulnerable niches, your interdental area. If you have a small malocclusion and there is a small niche where the toothbrush doesn't reach, these are the area, and your pit and fissures that are pretty deep. These are the areas where the niches develop. So this is constantly happening. The idea is to prevent this from progressing in a unidirectional, to try to push it back into thing. Now, coming on to the surface layer, we see that nothing happens on the surface layer actually. Why is this so? Is because the surface layer is constantly bathed by saliva, and it is a hypermineralized zone, especially more concentrated with your fluorapatite crystals. So after eruption, the tooth is constantly bathed with saliva, and hence this surface becomes much more resistant to acid attack. But the inner layers are not so remineralized or reinforced. So always, if you see, decay starts from a subsurface lesion, and it's not a surface phenomena, except when the tooth is newly erupted. When the tooth is newly erupted, the surface is a very virgin surface. This does not have the fluorapatite surface that is formed. It will take about 2 to 3 years for this fluorapatite layer to be formed. So if we are looking at preventing dental caries, it is the time to focus is the time when the tooth erupts into the oral cavity. Because that has more of carbonated hydroxyapatite that can be easily lost due to this demineralization processes. So that's the only place where the surface is vulnerable. The newly erupted teeth, it takes about 3 years for this post-enamel maturation to happen. And the dissolution of the ions takes place around the prisms first. So this is a cross-section of a demineralized enamel. You can see that the keyhole pattern of the enamel, where the central core is still intact and the periphery starts to loose out. Again, this is another defense mechanism by nature, wherein if the favorable environment returns, the periphery starts remineralizing, thus maintaining the core intact. But when acid production increases and is sustained over a period of time, then the central core also gets demineralized, and that's when you have microcavitations forming in your enamel. Now, the solubility properties of human enamel has been extensively researched, and this is a very useful publication which kind of states that this is the product solubility constant. And also, when we say solubility of enamel, you don't directly have calcium and phosphates coming out. First, only the intermediary compounds are released, which kind of buffers the acid. So the intermediary compounds are magnesium vitlookite and dicalcium phosphate dihydride. That kinds to slow down the demineralization process. So vitlookite is implicated in dentine caries, and TCPD is implicated in enamel caries. This is again another defense mechanism of the tooth. Then there are certain biological factors in caries that says that is what I was discussing about is the post-eruptive maturation. So this is the this takes the enamel that is vulnerable soon after eruption is about 200 microns. So if we don't protect the tooth at that time, then we will lose most of our enamel to demineralization at that time. So that's where you have fluoride varnish application program to be applied at strategic time points of tooth eruption. So this again, these are all native factors of the tooth and how the host or the tooth material itself plays a role in the pathogenesis of caries. Saliva extensively has been discussed in the previous lecture, so I'm going to keep it very, very minimal. Though lots have been discussed and deliberated, only 2 factors have found to be really of significance. First, and I've listed it in order of significance, the first is the flow rate. If the flow rate is intact, actually most of the problems are taken care of. It's only in cases of xerostomia or any salivary gland pathology where patients are highly vulnerable to dental caries. Coming on to the salivary flow rate, what does it do? It helps basically neutralize the pH. It has certain buffers in place, so it helps in dilution of the plaque pH. It also supplies nutrients, which helps in preventing plaque from constantly being formed, especially the ferrous salt that is present in the saliva is an antimicrobial in nature. It physically removes the bacteria from the site. So it helps in bacterial clearance, and it's a constant source of the potential minerals that are responsible for remineralization. And the composition, it has inorganic and organic. All of this has been discussed extensively. One point that I would want to bring in focus is the calcium binding proteins that I have marked in red. The proline rich protein and stearin. These are though present in saliva are kind of counterproductive in nature, because these are the calcium binding proteins that play a role in anchoring the bacteria to the tooth as well. So when you have the pellicle that's formed, these two substances kind of anchor or provide receptors to allow the bacteria to colonize on the tooth structure. So I'm not discussed much about saliva. I think if we try to increase salivary flow, most of the problem is actually dealt. And if somebody suffers from decreased flow rate, then they need to be taken care of separately. This is something that the next factor, the third factor that I'm going to discuss, is completely under our control. And it's just our mindset, I think, that needs to be regulated and tuned, the diet. So these are the components in diet that have a direct implication. The chemical composition of the food that we eat, its consistency, because that determines how sticky it is, that it will stick onto the tooth material. And thirdly, the frequency, how often do we keep eating? And predominantly it's been seen that complex carbohydrates are much more safer because they have a very low diffusion coefficient into the biofilm. The biofilm, once formed, does not allow these complex carbohydrates to percolate. So even if you have a cariogenic biofilm, if you just took complex carbohydrate, which means you just ate lettuce and carrots for a week and just decided to go on a week for a vegetable diet, you probably would stagger or lower the chance of developing demineralization under any biofilm. And the order of diffusion of sugar as such into the biofilm is fructose followed by glucose followed by sucrose. So these three components have a very high diffusion rate into the biofilm. So if you just take a spoon of sugar and eat, then it's actually party time for bacteria in your mouth. Now, what happens to sucrose is the bacteria possesses two enzymes, glucosyltransferase transferase and fructosyltransferase transferase, that immediately act on sucrose and converts them into glucan and fructan, which serves as their extracellular polysaccharide material and as an intracellular reserve. So don't we don't eat sugar at all? Do you mean to say that I need to cut sugar from my coffee? It's not that. We just need to see how this entire thing is processed. How is the polysaccharide material processed in the tooth? So when you have these salivary glycoproteins and amino acids that are present, so when you eat something, it gets diluted into your saliva as well. That, along with your salivary glycoproteins and amino acids, normal common cells still process that and develop acid, but they are all weaker acids. They are mostly acidic, butyric, and propionic acid, which has got a very weak dissolution coefficient, which will not etch the enamel too much. But when this salivary glycoproteins or amino acids are predominantly replaced by glucose, fructose, and sucrose, then S mutant starts producing more enzymes to break down these. It starts multiplying itself and more of lactic acid is produced, which is a very strong acid, which can shift the pH of the resting pH of the biofilm to a very low concentration that can cause actual demineralization. So in natural sense, also in normal people's mouth, even if you still took cucumber and carrot, you will have demineralization happening, but at a very, very slow rate because of weak acids that are produced, unopposed to what happens with glucose and fructose. So this is actually enunciated by your Stephen's curve. What is Stephen's curve is basically whatever we eat, it gets processed in the food. In fact, we have digestive enzymes in our mouth itself. So it breaks down whatever we eat, and thereon the bacteria start to process it. It all depends on how fast the pH is able to recover back to normal, or we all know the critical pH for enamel is 5.5 and that for fluorapatite is 4.5. How fast we are able to recover from below to above this critical pH determines the karyogenicity or caries risk in our mouths. It's simple as that. So if you actually have something really sweet and rinse your mouth immediately, then your caries risk comes down drastically. So it will not help in caries progression. But if you keep eating something and that's stuck somewhere in between your teeth, you don't bother to remove, then the Stephen's curve and the acid clearance from that particular site takes a longer time to occur. And this Stephens curve is different for different individuals. In a caries-free individual, the drop in pH itself will not be as much as that would occur in a caries active individual. Why is this? Because the choice of organisms that are present already is shifted. We know that in an extreme caries activity person, the ecological shift has already occurred. So the bacterial environment itself is different as opposed to caries-free individuals who only would produce butyric acid or propionic acid. So this Stephens curve will not bounce back above normal pH in caries active and extremely active individuals, and that's the problem, that people will keep sinking into that vicious circle of developing caries. So the diet also is the same diet, if you give a spoon of sugar to a caries-free individual compared to a extremely caries active individual, the way Stephens curve behaves in both these people will be totally different. So it's all got to do with the susceptibility. The third aspect of diet is frequency. So if you are disciplined in your food intake and just restrict to your regular meals and not focus on food at the rest of the time, then the risk of caries is very less and the disease progress does not occur actually. But if you keep snacking in between meals, especially now with the fad of this 16-9 fasting, what's it called, intermittent fasting that's in place, they say that you can eat whatever you want in that 9 hours that you have. So the idea and the tendency to eat whatever you want, like as frequently you want, it probably helps in your overall metabolism. I do not know that that research I have not explored, but the frequency of meal or sugar intake will have a detrimental impact on the development of dental caries, because you are constantly providing Streptococcus mutans its favorite food. So then the progression of caries is unstoppable. So frequency, I feel, more than I get a lot of patients in clinical practice who say that I don't give any sugar to my child. She's not touched chocolate. I feel it's a kind of crime to rob the child of its childhood. No, what is childhood if you didn't eat chocolates? I would rather say that you give her share of chocolate, but you give her it along with the meal time, so that she eats her meal, she has her chocolate, rinses her mouth, and then everything is fine. Rather than completely cutting off anything, because in life, I feel everything is all about balance. You have to have everything in place. It's not about eliminating something in order to achieve something else. So this is basically coexistence, and we need to encourage patients to have lesser frequency of diet rather than cutting out their favorite meal from their food. Now, sugar has been actually implicated heavily even by the WHO for systemic illnesses due to the onsurge of non-communicable diseases, namely diabetes and obesity. And their clue or their recommendation for sugar intake actually has come from the dental literature. And also the ORCA and European Academy of Pediatric Dentistry has put forth with this. This is the WHO recommendation for sugar intake. So we need to restrict sugar intake to less than 10% of total energy intake. So if you're looking at gathering energy through sugars, it might not be a very good idea. And we try to look at other source of energy intake, maybe your protein bars and stuff like that, instead of focusing on sugar itself. So this is the global recommendation for health, not just oral health, but general health, which serves good for dental caries scenario as well. Now, the last factor which leads to the formation of biofilm, which is the acquired pellicle, plays a very important role. This is nothing but salivary glycoprotein. It's an acellular organic film that gets absorbed onto the tooth material within hours of us toothbrushing. So it in fact immediately forms and it gets established within 2 hours of toothbrushing or oral prophylaxis. This is very, very helpful in it is again another defense barrier because it has transglutaminases, which helps in protecting the enamel. It offers some resistance to acid. It has got a lot of proteins in its in itself. It absorbed onto the surface, which helps to prevent acid influx into the enamel. Also, it forms a physical barrier, and it forms an electrolyte reserve for calcium phosphate and fluoride. But one problem with the acquired pericle, as with the saliva, is because basically saliva that is getting absorbed, is the base pair for bacteria to get attached or anchored to the pellicle, which is the steathinin and proline rich protein. So these are the anchoring receptors for calcium, but they are also anchoring receptors for the bacteria, and this is how bacteria actually starts attaching. So bacteria cannot attach to hydroxyapatite. It does not have receptors to attach itself to hydroxyapatite. It attaches itself to these two proteins present in the acquired pellicle. So this leads to the biofilm formation, and the biofilm, if left in place with constant sugar intake, converts into a karyogenic biofilm. So not all biofilm are bad. There is a certain shift in the biofilm itself for it to become karyogenic, which and the shift can be because of low salivary flow. That is a drastic and a detrimental shift, but this does not happen in a majority of population. The factors that are external to us, to the host, is sucrose and glucose. So if you keep eating this, then the shift is inevitable, and it will definitely happen. The factors that are associated with the plaque itself. So you have plaque formation, and that plaque gets converted to a karyogenic plaque. So there is increased sugar that goes into the karyogenic plaque, and there is decreased salivary inflow into the karyogenic plaque, which leads to increased acid production, excessive formation of the extracellular polysaccharide material, and also we are providing a reserve, the intracellular polysaccharide material, which is fructan. Gets like how we all have glycogen, Streptococcus mutans and acidic bacteria have fructan, which serves as a reserve for them for future use. So if you took loads of sweets for 1 week and they say that next week I'm not going to have sweets and I'm not going to be in the karyogenic zone, we are all mistaken, because the bacteria already has had its reserve, and if it is hiding in some ecological niche, then the caries process will still continue. So what happens with bacteria and sucrose? We all know that it gets defragmented, it forms lactic acid. Then you have certain specific enzymes, the glucosyltransferase transferase, which converts sucrose to glucan, which forms the extracellular polysaccharide material. So this glucan is nothing but a glue. This will help other bacteria to come and stick to it. In a normal plaque, what we call as just general plaque, does not have so much of glucan in it. It's only the S mutants that contributes to excessive glucan production. And then there is fructan that is formed that provides extracellular nutrition, and then there is also intracellular polymer deposition and glycogen itself that gets stored into the bacterial cell. So this is what happens when we all consume sugar. Now, if you see the composition of this biofilm, predominantly it actually contains water, and the remaining part, 80% is water. The remaining part is composed is the salivary proteins, because salivary pellicle is what forms the surface attachment for biofilms. Then you have glucans and fructans that are processed by the S mutants. So this will help in attracting and help in the addition of other bacteria. So when we all party, we all call our like-minded people, right? So S mutants being acidogenic and acidutic will call only other acidogenic and acidic bacteria to its party, and that starts populating onto the tooth surface. So if you see the kind of bacteria that are formed are totally different, starting from the basal layer. So the basal layer, you have actinomyces. There are more of anaerobic or facultative aerobes, which does not need oxygen to thrive. So those kind of bacteria start forming on the basal layer, and the ones that get added onto the top are predominantly Streptococcus mutans species. So So S mutans is there. It calls in the bacteria. It pushes them to the basal layer. It comes on top, and yes, no, this process keeps happening. So this Streptococcus mutans acts as some kind of a recruiting agency of other bacteria into the biofilm. Now, the biofilm itself is the actual reason why demineralization happens. So there's nothing wrong in the mouth, there's nothing wrong on the tooth, but if you have biofilm stuck in a particular space for a long period of time, which is not removed by toothbrushing or flossing, then there is a problem. And the development of biofilm, we all know, I'm not going to go into the details of it. You have the pellicle formation, and top of this, you have the bacteria that get absorbed due to van der Waals forces or due to direct attachment with the salivary glycoproteins. Then you have microbial succession. So as the biofilm thickness grows, you have more and more of anaerobic bacteria that gets placed there. They are also acidic and acidogenic, but they form the basal layer. And then you have the other bacteria that colonize on the superficial layer. And then you have this biofilm that is formed that's like a full-fledged army that is working constantly at processing sugar. Trust me when I say that S mutants is not the culprit. It's a sugar that's the culprit. And S mutants is just taking use of the opportunity there. So it is having a ball of a time, and it's constantly upgrading this biofilm. Beyond a certain point, the biofilm does not increase in thickness because it becomes too heavy for its own cell. So the top part branch is in control along the more and more bacteria. So in the same process, the microbial succession and mature biofilm formation stages will get repeated over a period of time until this entire biofilm is physically removed either by toothbrushing or by any other intervention methods. Now, for the sake of postgraduates, I would like to turn all of you to this particular publication, which is very, very comprehensive. In fact, if you want to read about karyogenic biofilm, these are the two authors you should look at, Bowen and Koo. They've done some phenomenal work in trying to analyze what is happening within the biofilm and try to give the heads up. And this is how they have pictorially depicted the biofilm. So it all starts with the salivary factors and sugar-rich diet. So when we are saying etiopathogenesis of caries, it all starts with sugar, because all of us have adequate amounts of saliva in our mouth. Xerostomia is not something that we all suffer with. So it all happens with sugar and probably poor oral hygiene. Initially, you have the pellicle formation and the microbial colonization that is seen on the top border. Once you have this yellow thing that's happening, that's the extracellular polysaccharide material that gets deposited. Once that happens and bacteria start colonizing, then you have active acid production. Now, this glucan and this biofilm itself is like your adhesive tape. It is very, very tenacious, and it does not allow things from the saliva to permeate into the biofilm matrix. So it is so tenacious, it allows the bacteria to thrive. Bacteria is protected. So if you just think that over this biofilm, if you run, just took a mouthwash of chlorhexidine, chlorhexidine is a potent antibacterial agent. It will kill bacteria in a minute. It will do nothing to the biofilm. So the bacteria that's present inside the biofilm still remains protected by various chemotherapeutic agents that has been tested. So the problem will continue and increase. In fact, it's counterproductive to use chemotherapeutic agents because they will bring down the oral commensals as well. So they don't do anything to the oral biofilm, but they degrade the oral commensals as well. So once this ecological niche is established, then there's a huge component which plays a significant role, which is the quorum sensing. Quorum sensing is a separate science in itself. When we speak on oral biofilms, I'm not discussing too much on quorum sensing because it's a huge area of research, and it's actually a current area of research in karyology as well to see. So what is quorum sensing? It's basically messaging between bacteria to bacteria. Imagine that now we get information about COVID, we forward it to 10 other groups and they are now aware of COVID and they know we take turmeric. Now, millions of us have been using turmeric mouthwashes for preventing COVID. It's all because of WhatsApp communication. Similarly, the bacteria has something called as quorum sensing, which keeps sending signals constantly to update the other bacteria present within the biofilm to make sure that they are all safe and secure. Apart from sending out signals, they actually also transfer genetic material. So if you have a particular bacteria which is resistant to chlorhexidine molecule, and that genetic material can be transferred to your actinomyces within the biofilm. So all that is happening because of your quorum sensing, and that is actually the current area of interest. Now, this is the kind of battleground that is elucidated. You first have basically the early colonizers are actually commensals. They are not karyogenic bacteria. So Streptococcus salivarius and Actinomyces niacinae, they are all normal commensals. So does your Streptococcus mutans. But with your sucrose intake, more and more of Streptococcus mutants form, their genetic expression changes. So that's what you've seen in that box. So there is when they bring in all the other karyogenic bacteria in place, and they all start producing extracellular polysaccharide material that kind of protects the enamel, that protects the microorganisms, but the microorganisms are happily sitting there producing acid and causing Caries lesion to occur. So this is what happens. So why it is important for us to look at it in such a complex manner is, we all thought that eliminating bacteria will help us conquer the disease.
Both of it down.
So we used to prescribe triclosan mouthwash or triclosan-based toothpaste. Chlorhexidine mouthwashes were prescribed. So the so-called medical model, all targeted at reducing the bacterial count. But when we are trying to reduce the bacterial count, we are also reducing the normal commensal count that can again become counterproductive. So you have opportunistic candidal infections that come into place. So the strategy to prevent this biofilm from forming is actually moved away from antimicrobials per se, and more focus is being laid on how to disrupt this extracellular polysaccharide material. So if you want to try to devise a compound, try to see what can disrupt the extracellular polysaccharide material, because if you target S mutants is a commensal, so that will get eliminated even in normal oral flora, which will offset the balance. We don't know what will happen, but something really bad will definitely happen. So the idea is to limit the extracellular polysaccharide material. Other area of research is to try to replace this Streptococcus mutans with other bacteria. That is the whole concept of probiotics. So this probiotic bacteria, predominantly Lactobacillus, competitively binds in the place of S mutants, thereby preventing, and this genetically engineered probiotic bacteria are not able to synthesize sucrose. So they will not produce acid. They will go and catch their place over there, but they won't do anything. So these are the strategies that have been tried. I've been trying and testing now. And this is where we also need to focus. Inside the karyogenic biofilm that helps in distribution of sugars, and it also can scavenge sugars from the oral fluid. So this is happening in a karyogenic biofilm. Their ability to ferment and maintain metabolism even under low pH is something that helps them thrive in a karyogenic environment. Predominantly, Lactobacillus and S mutants are implicated in this, which are both acidogenic, acid producing, and acidic acid thriving, thus help in maintaining a favorable intracellular environment. They provide enzymes to maintain an acidic pH, and they also produce acid stress proteins which will protect this ecological need. And they also help in the production of intracellular and extracellular polysaccharide material that strengthens and concentrates acid within the biofilm. As I told you, the biofilm, you could probably attribute this kind of a biofilm to a plumber's tape. So nothing will escape out of it. So that's what happens in a cariogenic biofilm. So not all plaque are cariogenic. We need to understand that if you say a patient who's undergoing fixed orthodontic therapy, they'll always have some amount of plaque sticking onto the tooth. That's not cariogenic. Cariogenic biofilm is something that all of these should happen in that. So for that, it has to be in place for a long time, and it has to have a constant source of sugar. So managing dental caries is actually very simple. You need to restrict the frequency of sugar intake, maintain adequate salivary flow, and maintain good oral hygiene. And then this disease is easily preventable from all sense. So the take-home message from my side would be that it's a complex interplay of the primary factors. We are all looking at so many other things, but the primary factors that I've just discussed are the important things to focus on: your tooth, your saliva, the sugar or the food that we eat, and the biofilm that gets formed onto the tooth surface. So these are the factors that we need to take stock of. Cariogenic biofilm are more relevant than the other oral parameters. If you say that I at least did my undergraduation in the 2000, I passed out in 2002. So it used to be a very common public health dentistry question: caries susceptibility test and caries activity test. So we used to write some 10 tests. We'll be there, we'll write, we rest assured get the 5 marks for that question. But these days, those tests are all not relevant. So if you're trying to look at assessing risk by measuring salivary pH and salivary bacterial count, then it is not actually going to help. What we need to look at is what is happening at the cariogenic biofilm level. So in that microenvironment, what is happening is what will dictate how the disease is going to progress. So the research is shifted from your entire salivary analysis into directly to your caries risk. Why is this important? Is because that's where we need to program and plan our intervention or interceptive methods. So that's where you need to target and disrupt the disease from progressing. The antimicrobials do have a role, but they are only restricted. Antimicrobials in the sense the antimicrobial mouthwashes, chlorhexidine and triclosan do have a role, but they have a role only in patients who have very low salivary flow or in patients who have very high caries index. So to bring down their bacterial count, we will prescribe antimicrobials. In all other sense, the way we go about managing the dental caries based on what we have understood through etiopathogenesis is to control for the primary factors. So with that, I would like to bring in or mention my favorite team from Meenakshi Ammal Dental College, because that's where I started my journey with cariology, and each and everyone has been so supportive of what I wanted to do. They've always held my back, and I miss them a lot. And I'm also grateful to my alma mater, where I've joined in after 17 long years to start this department of cariology at Savitha Dental College. And I'm really thankful to the management to have thought of dental caries and its significance in the population as a separate entity. And I cannot thank them enough. I'm trying. It's been 1 year. My students are taking up, third year students are taking up their cariology exam next week. I'm also equally, jittery. And I think it is a wonderful experience thus far in Savitha, and I look forward to contributing more and more from my side. And thank you all for your patient listening.
Yeah, thank you, Dr. Kritika, for more informative, wonderful lecture which is delivered in a very simpler way. Thank you so much. Now it's the time for question and answer session.
Ramya, can you please take over?
Yeah. Thank you, Dr. Mahalakshmi, Dr. Madana, Dr. Rajkumar, and your entire team for bringing out this much needed and much relevant topic as main topic for your session for the next 2 days. Thank you once again for inviting me also to moderate today's session. I'm really happy that I moderated Krithika's session because it's always a pleasure to listen to her. She has her unique, lucid style and inimitable style of presentation, which makes matters very simple. She has done a very exhaustive and extensive research on this topic, collected so much of valuable information that is even, so much is also new to me, and I've learned a lot from what she has presented. We are actually bombarded with a lot of questions, so I don't think I'm going to sum up her presentation because she's done the job very well, so I don't have to add any more to what she has said. But there are a lot of questions from the audience. This goes to show that they have been very receptive to her presentation. So let me start off with the first question. One is, what is the association between hormones and dental caries? This I found something not always thought of, so I thought I would put this as the first question.
Yeah, so the hormones and dental caries have been researched, and a few hormones that affect the metabolism of calcium and phosphate, like parathormone and thyroid hormone, have shown to have some implication. It's there, and also, though not a direct implication in the oral environment, the lack of insulin has had a profound effect on dental caries because it is known to drastically lower the salivary flow rate. So if you have anybody with diabetes mellitus, apart from the fact that they are having a different ecological niche, the predominant requisite, which is your saliva itself, is compromised. So yes, that's one hormone that will have a direct bearing for us in our day-to-day practice, but to a lesser extent, hypothyroidism can also, have an impact on calcium metabolism.
And another question is about the genetic factors in dental caries.
So genetics has been researched. In fact, human genetics has been researched. Also, S mutants genetics has been researched. So when we say genetics in dental caries, we have to look at these two things together. The human genetics is very simple and established. If your mom had too much of caries, you're bound to have too much of caries. So we've all seen WhatsApp ads forward that says that if your mom is intelligent, your offspring will be intelligent. So the same holds true for dental caries as well. Now, coming on to the genetics of S mutants, they've seen that S mutants genetic makeup is also constantly undergoing a lot of mutation and transformation, which produces more and more of acid producing nature and to resist any antimicrobial nature. If you see, chlorhexidine is actually banned in most of the European countries because of genetic transfer of the resistance factor. So they no longer advocate chlorhexidine mouthwashes in most of the European countries. So genetics both ways. In human science, it's very simple. They've also seen that genetically, those who are a chance of developing diabetes and obesity also will have an implication for dental caries. So they'll have to watch out more.
Okay. Dr. Pratima, you want to ask anything?
And just an observation which I think I have made in 25 years of my practice is that there is a definite demarcation between caries incidence in urban as well as rural population. So can you throw some light on that, especially amongst the children?
So the caries incidence in urban population is, I think, pretty straightforward. Is basically easy access to fermentable carbohydrates. But if you see, the caries incidence in rural population is also equally high. So in Indian population, if you see, there is not much of difference when it comes to incidence of caries. The reason why rural people develop more caries is because of lack of awareness and lack of access to healthcare. And what happens in the urban population is because they have easy access to fermentable carbohydrates. In fact, nowadays, I think most of the schools put a blanket on what can be stocked in their canteen. And even food menus have been prescribed by schools that say that don't eat a lot of junk foods. Though they are all aimed at minimizing childhood obesity and childhood diabetes, I think this is also a favorable move for dental caries prevention as well. But yeah, there are different factors that play in urban and rural sections, but caries is a pandemic in India.
Okay. Dr. Krithika, can you say something about the role of selenium in dental caries? Because the previous speaker, Dr. Ramya, spoke about the role of selenium. Can you just throw some light on that?
So selenium also, as she said, it has a selenium in saliva has a role in preventing dental caries. It is selenium, if you take as a molecule as such, is an antimicrobial. It prevents the oxidation pathway of the microorganism. But my problem is, how will the selenium go through the extracellular polysaccharide material of the biofilm? Because for any antimicrobial agent to take effect, it has to go through the cariogenic biofilm and reach the bacteria. Unless that happens, we will only be researching 100 odd antimicrobial agents, but it's not actually reaching where it should be reaching. So my urge would be is to, if you want to research on something, don't research them on planktonic forms. You need to have a baseline planktonic bacterial profile data, but you need to study the same thing in a biofilm data as well. So for you to show that, okay, it is also working in a biofilm environment. So selenium, yes, it does have an effect, but how far does it go through cariogenic biofilms is something that we need to look at.
Another question is about systemic acidosis. Is systemic acidosis an initial event in the etiopathogenesis of dental caries?
Yeah, there is another hypothesis that I have deliberately avoided incorporating in my lecture is the systemic acidosis. For those who are not aware of what systemic acidosis, let me briefly touch upon. What they say is that in your serum or in your blood, when it is in an acidified nature, like diabetic ketoacidosis, if that happens, then what happens is the same blood that goes to different parts also reaches your inner dentine layer, demineralizes the inner dentine layer and the inner enamel layer, and makes the tooth vulnerable to external impact. So this is the hypothesis of systemic acidosis concept that has been reported, but I don't think we've had hardcore evidences to show that cause-effect relationship, because systemic acidosis can happen in a lot of patients, and it happens even in normal individuals. Even in younger individuals, if you don't eat something for some time, you will go into a state of systemic acidosis for a short time. But how much is that? So what is the duration to which this systemic acidosis should prevail systemically for it to cause changes in the peripheral tissues is still not been reported. And we in fact had a debate within our students here. So I am aware of this concept, but I'm not fully convinced with its hypothesis. So we have to wait and see how they are going to present defense for that.
Any more questions, Pratima?
Brilliant presentation, Krithika, like always. I think you've answered most of our queries. Very good, very nice.
I think I got, hello?
Yes, ma'am.
You're here, Ramya.
Yeah. One more question is about some of the important environmental factors which are responsible for the etiology of dental caries.
So the environment all boils down to sugar or fermentable carbohydrates. So if we can educate our patient to time the intake of this one particular entity, then I think by and large, most of our patients will benefit. So we have two kinds of patients who come to us. When I'm saying come to us, I'm talking in the sense of a college setting. is that people who are generally unaware of the disease itself. It is very easy to treat them because you just need to educate them and show them how to brush, where to brush, and how to eat, when to eat. Then a lot of caries incidents can actually come down. So that way you will be controlling their microenvironment. But there are certain cases where there is some derangement in the saliva itself that will contribute to a very smaller fraction of patients. So in them, that's a challenge. So the environment needs to be studied, understood, and then a treatment plan to be devised. So by and large, if you see the way we are documenting dental caries separately using ICDAS in our population, and the way we do it is to not make it too elaborate. What I have seen from the foreign population and the foreign documentation is that they take in too many data when it comes to risk assessment. They ask you to do S mutants count, they ask you to measure the volume of saliva, and all that is not practical in an Indian scenario. And the recent publication by Martington, since it is not under my topic, I was not able to furnish that evidence, but Martington et al. In 2019 have simplified this caries risk, and they've just given some 8 factors which you need to estimate at the time you see a patient. So if even one factor is present, then you just categorize the patient into a high risk category. They don't have something called as a moderate risk, because this moderate risk becomes a gray area. Whom will you call moderate risk? How to calculate moderate risk? So they have only 2 categories, high risk or low risk. And one of the 8 parameters that is there that they've listed is any one decay extending into dentine, that is cavitated decay that is present in the last 1 year. So if you apply this category onto the patients who visit our hospital, almost everybody is a high caries risk patient. So most of the patients visiting dental hospital are high caries risk patients. So we just need to follow a blanket treatment. And the exercise that students in Savita follow is not to just assess risk and leave it at that. We make the student to call that patient back after 3 months and assess risk again, and see if they have maintained their DMF status or it has increased. So that is how you will treat the disease. It is the same concept of how we go about treating diabetes mellitus. You call events first diagnosed, you call the patient every 6 months to regulate their oral hypoglycemic. So same thing has to be done even in dental caries, being it multifactorial. You need to see the patient more often from the first time you diagnose that this person is having high caries risk, for 3 months in turn for the next 1 year, and then 6 months for the second year, and there onwards every 3 years if the patient is able to come, then you would have stabilized the disease for them. So the kids here actually document today, call the patient back after 3 months. Though most patients don't come back, we have set a quota that you have to submit a recall documentation of so many patients. So we try to assess risk reduction by longitudinal follow-up. So that's when you can say that you have actually controlled the disease. So that way you can also keep a tab on the patients.
Okay. One more question is, how do you manage, like, what are the preventive measures that you can institute for patients who are night workers? Like most of our IT professionals, they work at night. So
yes.
Is there any increased risk for such patients, and what precautions you can take for such patients?
So when usually night workers are the people who are predominantly engaged in the IT companies, their entire circadian rhythm, if you see, will change. It is entirely offset, and it's not just the oral parameters that get changed, but the entire physiology is changed. They sleep at a different time, and then their salivary flow rate actually goes down during the daytime compared to when they work. So, and also the tendency to constantly keep snacking on something to keep themselves awake during nighttime is higher. So, and also to keep sipping on coffee or Pepsi is also something that we frequently see. So it is just some lifestyle changes that they need to do. Instead of water, they can probably have some cucumber infused water to add some flavor and swag, but definitely no frequent snacking, or at least have a conscious eating pattern, because they don't have they don't follow the regular breakfast, lunch, dinner format. their format is totally different. So it is good that they are advised to stick to a particular format, devise a format and stick to that particular format and constantly eat in that format, so that the oral physiology also gets adapted to this new change.
One last personal question from my side. I hope Mahalakshmi will not
Just one
mind
more.
it.
Yeah, just one
Yeah,
more. We are
one more.
actually
Yeah,
running
just
almost
one more.
1 hour late.
Okay. Yeah.
Just one
I
more.
just have
Thank you.
this, this is my observation in my private practice. A patient who's, high consumption, who has high consumption of alcohol, has an increased rate of dental caries. Now, how do I sort of tackle this?
That is obvious, because alcohol causes dehydration, and dehydration will certainly affect salivary flow. So if they are having 3 shots of their favorite drink, then they would also have to follow it up with 2 more liters of water. It is generally advisable for their general health also, because they will go into an acidogenic state physiologically. They get dehydrated. So yeah, if you're fond of alcohol, you also should embrace water in your lifestyle. Because it's very difficult to say an alcoholic not to drink.
Not only in the drink, but also after the drink, probably.
Yes.
Okay, thank you very much, Krithika. I know we don't want this session to end with having so beautiful speaker and so beautiful moderators, but still time doesn't stop for anyone.
Thank you.
Thank you, Dr. Mahalakshmi.
Thank you, Krithika. Thank you, Dr. Maha. I enjoyed this session thoroughly.
We still have not winded up. Madana, please do the honors. Madana, you're not audible. I think you need to unmute.
Mute.
We'd like to express our appreciation to the speaker of the session, Dr. Krithika Datta. And also we also like to extend our appreciation to our moderators, Dr. Pratima Chennai and Dr. Ramya Raghunath.
Thank you.
Thank you once again.
Thank you.
Bye.